some of you at the office, but for those of you I haven't met, my name's Kori. I'm a nurse practitioner. My specialization out of school was in family practice, and then I transitioned into internal medicine and some regenerative medicine in the wound care field, and that sort of transitioned me over into more of a wellness-based, holistic health and regenerative practice as far as the whole body goes. So I do have advanced training in the use of peptides and bioidentical hormone replacement, weight loss, and some joint injections, as we're going to talk about. I am married to my husband. We've been married for 9 years, and we have a son, Jackson, who's 3, who I do not homeschool or stay home with. But I envy the fact that you could do that. That's impressive. So you all are probably here because you have a concern of some sort of a joint injury or pain or something along those lines that you're wanting to get addressed. And so a lot of folks that come in and talk to us, they're looking for an alternative to surgery, or they've been told over time that there's nothing else that can be done. So we're kind of here to talk about some of those are alternatives. And for some people that's just one joint that bothers them, and for others they have several issues going on. So we can talk about more individualized concerns if you guys have specific questions, but we'll kind of go through a generalized review. So most of the joint injection, inflammation, breakdown in the joint, and the lack of your body's own growth factors and stem cells as we age. So in terms of how we fix that, Dr. Endel and I, we approach it in a stepwise manner to kind of address all of those issues with degenerative joint disease. Now, degenerative joint disease can happen just as we age, but a lot of times it's related to some sort of an injury that may have happened when you were a teenager or in your 20s or 30s that kind of stays in that inflammatory state and then leads to more rapid progression of that joint disease. So the thing that this more mainstream type of medicine can do compared to the traditional approach is that we're not trying to put a Band-Aid on it, right? A lot of people have had cortisone injections or maybe even arthroscopic surgeries or things like that they're just kind of putting Band-Aids on things. And so what our goal is to do is to actually help your body restore the tissue that's damaged, and hopefully create more of a pain-free day for you. So a lot of times traditional medicine approach in the orthopedic groups, in medicine, we follow practice guidelines, right, where experts get together and they say, this is the best choice of treatment. And for orthopedics, a lot of times that's first we take an anti-inflammatory, right? So we're told to take an NSAID, like ibuprofen or Advil, or maybe even prescribed an anti-inflammatory like meloxicam. And those do reduce inflammation, but what we know is that folks that take those anti-inflammatories long-term actually have more trouble down the line if they're taking those after an injury. We know when we look at x-rays from folks that have been on long-term anti-inflammatories versus not, their progression of disc degeneration in the joint and in the back is worse. So we're trying to look for an alternative for that. The other issue is if we get to failure with an anti-inflammatory, then sometimes we look at a steroid injection. And if a steroid injection doesn't work, then we look at a gel type of injection that's put into the knee or into the joint. And if that doesn't work, then you're told, okay, we need to do surgery. But there are other alternatives to that. And surgery is a serious thing. Once you make that cut into the body and you go in and you affect that joint capsule, there's no going back from that, right? And so the statistic is about 70% of joint replacements that are successful, but that 30% have some sort of complication where either doesn't solve the problem, right? They still have pain, or they have a complication with infection, right, after the surgery. That's not uncommon to happen. So in addition to that, you know, there's a significant cost. So that's what we're trying to address. And we kind of already went over some of this, but you know what Dr. Indel and I are focused on is trying to focus on the health side of things, on letting your body actually repair that rather than treating that your body as that it's sick. So the different treatments that we're going to go over tonight, you know, we do follow somewhat of a stepwise approach, but every patient we see is individualized. Some of these treatments that you hear may not be appropriate for you, and that's something that we can go over in detail. There are some of these that are going to be more beneficial for a soft tissue injury versus advanced arthritis, but we'll go over them in a broad spectrum here. So what we are trying to do is ultimately to increase your quality of life and reduce your disability, and that can be in terms of any of your joints. You know, we do trigger point injections, we do treatments for neuropathy, right? These peptides can help with into the actual joints themselves, which I think most of you have had issues with. So the first step that we look to address is addressing the inflammation that's going on in any joint that's having a problem. And we know that inflammation has been there for probably years and years for the joint to get to the state that it's in. And so pentasand polysulfate, and I'm not sure if you guys can see this okay, it looks kind of small, but it is a peptide, right? And a peptide is basically a protein that has a message that we're delivering to your body to do something that it does on its own. But we're giving your body more of that message, if that makes sense. So pentasand, it was originally studied for interstitial cystitis, which is an inflammation of the bladder that causes chronic UTI symptoms, and it's been FDA approved for use with that in a pill form. But what we know is that when we use pentasand polysulfate in an injectable form, either on a short-term basis or a long-term basis, it decreases the inflammation not just in the bladder, but in the body in general. And so it is a potent anti-inflammatory, stronger than a steroid, right? You've heard about getting a steroid injection either into the joint or a steroid pill if something's very flared up. So this is an alternative to that, along with an alternative to an NSAID. And so it's got a clean side effect profile. It has a mild blood thinning effect, but it is safe for someone to take who is already on an aspirin or some sort of blood thinner who can't take an NSAID. And so the pentasand polysulfate is kind of our first step into cutting out that inflammation. And we also have an injection called an alpha-2 macroglobulin, A2M injection. We'll get into that here in just a moment. But both of those are going to address the inflammation going on in your joint, so that if we decide to do a PRP injection or a stem cell injection or an exosome injection, your body is ready and primed for that. So we're trying to take care of the joint to prime. The other two peptides that we utilize are BPC 157, which is body protective complex 157, and thymosin beta 500, TB 500. And so those again are both proteins specifically that are injected. Those are injected on a daily basis, generally for 8 weeks or so, and they are going to work again on that anti-inflammatory nature. However, the thymosin beta 500 has some healing properties in terms of telling your body to kind of pump up the amount of new cells that it's making, and the BPC 157 is even more potent in that. So, you know, we know when we have an injury that our body starts a healing cascade, and it brings all of the inflammatory cells there to heal, whether that's a hangnail, a big surgical cut, or you know, an ACL tear, something significant like that. We giggle because we've probably been there, right? Okay. And so when we have an injury, our body starts this inflammatory cascade, and it brings increased circulation and increased growth factors and cytokines and all of these cells that are meant to heal. But after a while, if the body hasn't healed, it gets stuck in that inflammatory state. And that is where the cells don't function well. So on top of our bodies aging and not working as efficiently as they used to in terms of making new cells, clearing the old ones and building new tendon and building new cartilage and building new bone, we're stuck in that inflammatory state where the cells that we do have aren't able to do it as well because of that. So these peptides are used not only for the inflammation, but the latter two in terms of promoting healing as well. We do occasionally put BPC 157 into a joint itself, but most of the time these are going to be given in the subcutaneous tissue, so through a very small insulin needle or like a Botox needle, right? It's very small. Most of the time you can't even feel the pinch into the top layer of skin. So they're absorbed systemically, so it doesn't really matter where you administer it. Most people administer into their belly, and it's just a very tiny needle that you inject. Now, those are injected every day for, like I said, about 6 to 8 weeks. And sometimes those peptides by themselves, along with the pinosan, are enough to stop the inflammation. Your body starts doing what it needs to do, and your cells are healthy enough that you don't have to go any further. But in order to get true regeneration of that joint, this is basically a priming step to be able to utilize those other injections. So the other big player that we have in terms of reducing inflammation and kind of stopping that inflammatory cascade is what's called an alpha-2 macroglobulin. So you've probably heard of PRP, right? Platelet-Rich Plasma, where we take your blood just like if you were donating blood or getting a blood sample drawn. We take a couple tubes of blood and we spin that down and we take the red blood cells off, and it leaves us with a plasma that is exactly what it says, rich in platelets. So that is a great type of injection in terms of mild arthritis or a soft tissue injury, right? If someone just has a tear. But once we get to that moderate arthritis stage, we're usually stuck in enough of an inflammatory state that the PRP isn't very beneficial, because when we put that PRP in, we're bringing inflammation to the site, and we're wanting to avoid that with most of that advanced degeneration. So the alpha-2 macroglobulin is a further step in the PRP process. So we do PRP, and then we spin that down further to isolate one specific protein, the alpha-2 protein. And it does play a small role in the clotting cascade, but it's mainly a protease inhibitor, which in layman's terms means it stops inflammation. So all of your cells start to work more efficiently. And what we know as far as data goes on the alpha-2 macroglobulin is that it not only stops the inflammation, but we can see on images after people get these injections that the further degeneration of the joint stops. Right, so it basically halts that arthritis phase. We know, you hear people say, "Oh, I had arthritis in my knees. It's getting worse. It's getting worse," because it is a progressive type of disease. It's a chronic disease, and so this alpha-2 macroglobulin is one of the first types of injections that really has been shown not only to reduce the inflammation, but to actually stop that further progression. So kind of already went over this a little bit, but we draw blood from a vein in your arm and we spin that down and then inject that into the joint. Generally, one injection is all that you need with an alpha-2 or an A2M injection, and that can be used with or without those peptides that we talked about. PRP, so this is that concentration of the platelet-rich plasma. The benefit that we get from that is that plasma is rich in cytokines and growth factors and all of these cells that we don't have enough of in our joints. And so when we use those, we're taking the cells that your own body has. So however old you are, your PRP is going to be of that age. And so the only drawback from a PRP injection compared to like a stem cell injection or an exosome injection is simply the age of the cell. But they do similar things there. So like I said, the PRP is going to be good for soft tissue injuries or mild arthritis. And I don't know how many people are dealing with more soft tissue injuries than arthritis, but I'm happy to go into more detail if we're looking at that too. Again, this goes through the fact that it's turning off the inflammation and we're telling your body to heal itself. The good thing about PRP is that it comes from your own body, right? So the stem cells and the exosomes, they are technically donated tissue. So the PRP is autologous, meaning that it's from your own cells and uses the body's own mechanism that way. Stem cells, on the other hand, there are ways that we can get autologous stem cells by harvesting your own stem cells from bone or fat. Usually fat is the one, bone marrow in the OR type of setting, but usually in the outpatient setting from fat cells. And so they are effective, and it's a good treatment for someone who maybe doesn't qualify for a donor stem cells because maybe they take a medication that prohibits that if you've had a transplant and take an anti-rejection medication or something like that. But for the most part, they're not utilized as much simply because they're not as potent. So if we think about the age of your cells, the age of, or the potency of a stem cell of a newborn is going to be much more potent than stem cells in someone in their 30s, 40s, 50s, 60s. And so if you think about how quickly kids heal and how resilient kids are, that's why, right? As we age, we get these chronic diseases because our bodies aren't regenerating. So the stem cells that we utilize, they're allogenic stem cells, meaning they're donor and stem cells, and they come from live births. Yeah. So they're not embryonic stem cells. They don't come from the baby themselves. They're donated tissue either from the placenta or the umbilical cord, and it's something that the mother is given consent to prior to birth. They're screened just like an organ transplant would be for any types of infection. They're definitely safe to use. But the benefit of the stem cell going into the joint in terms of repair is that stem cell can turn into whatever your body needs it to turn into, right? So we can use that stem cell and we could say inject it near a muscle, and it's going to turn into muscle if that's what your body needs. We can inject it into the joint and it's going to turn into new blood vessels if it needs new blood vessels, and new nerve endings if it needs new nerve endings. It gets the bone, the cartilage, the muscle, everything kind of can come from that stem cell. And so the way that benefits the healing time frame is that obviously it's shortened. Now, these degenerative processes didn't happen overnight, so they also don't go away overnight no matter what we do. But with stem cell injections or exosome injections, we see generally a lot of improvement once we get to the 3 to 6 month mark. And we give them a full year to really get the full impact because we're letting those cells do what they need to do and multiply every day.
In comparison to PRP, what is the timeline?
PRP, we're going to have more inflammation during the first 30 days. Right. Usually 6 months, you're going to be at about your max outcome for that. Yeah.
I've still got 4.5 months to go to that.
Yeah. Now, occasionally we'll utilize, PRP after we do a stem cell treatment, and the benefit to that is to kind of bring some of that inflammation actually back to the joint while we have those healthy cells there, to bring more circulation and more of your own body cells. But for the most part, we're going to get a quicker response from stem cells than PRP because of that. So PRP, usually the 6 month mark. Stem cells, we see the improvement more quickly, but also lasts a longer time, if that makes sense. Onsets more quickly.
Can you go through IV stem cells?
IV stem cells. So it's not something that we do currently, but it is definitely a more common thing to occur. So stem cells can be given through an IV, thought being that if you give these stem cells that can turn into any type of cell through a systemic manner, they can help heal. Right. If we're having low brain cell counts because we're starting to get some dementia, or we're having issues with the gut, right? They can differentiate into whatever needs to be. So we kind of went into this already, that the fact that they can become any type of cell, and they build that new tissue. Autologous stem cells, those are the ones that are taken from your own body, and then the allogenic stem cells are the donor cells. Sorry, I guess I got ahead of my slides here, guys. So the stem cells that we talked about are what are considered mesenchymal stem cells, and the difference between those and other type of stem cells in terms of controversy or ethics, right, is that these aren't embryonic from embryos, or they're only from live births. So in terms of ethics, that's the type of product that we use. Are there other ones out there? Yes, but that's not what we utilize. This kind of goes into those IVs again. Anytime that we do a joint injection, we really want to rest that joint. So when we would time an injection, whether it's with PRP or stem cells, we want the next 30 days or so to be sort of a break for that joint, not something where you're going and playing pickleball or going in and running, right? Like walking on a treadmill, probably okay. If we're doing like a shoulder, for example, right? You're not gonna be like swinging your arms a lot. But if we're doing a knee, doing a lot of activity during that next 30 days, not ideal, because we want the body to heal while it has those cells there, as opposed to increasing the inflammation when we don't want it to be there. You'll hear the term Wharton's jelly in terms of stem cells, and that's just the gel from the umbilical cord, and the products that we utilize do come from Wharton's jelly. This goes over how many stem cells that we have in terms of age. So to put in perspective, like a newborn baby has approximately 1 mesenchymal stem cell per 10,000 bone marrow cells. And once we get to the age of 60, we have about 1 mesenchymal stem cell out of 2 million bone marrow cells. So it plays a lot into not only degenerative joint disease, but chronic disease in general, with heart, lungs, and everything like that. And when we talk about chronic diseases, a lot of people will, if they're told they have heart disease, they treat it right away because it can kill you, right? Or if someone is told like they could have a risk for stroke, they treat it right away because it could kill you. And so a lot of people put up with this chronic joint pain for so long, and it does impact your quality of life, and eventually that change in activity will catch up, right, and allow other chronic diseases to take hold. So in terms of importance, I think in medicine in general, we downplay the importance of joint health. We already kind of went over that. So there's a risk, obviously, to every treatment that we do. The most common type of reaction is going to be an inflammatory reaction after we do the injection, and that's to be expected, right? We're injecting something into the body that's foreign. We're increasing the inflammation, so you can notice increased soreness, increased swelling, sometimes even a little bit of redness from that inflammatory reaction. It's very uncommon to have an allergy to something like this because these are all natural cells that your own body produces. In terms of infection, that's a very low risk. We do everything sterile in terms of the injections. There's a risk, that the medication or the therapy doesn't go into the joint, into the right place. Dr. Indel has an ultrasound that allows us to image the joint if there's any concern where we can't palpate and we're not confident that we're in the joint space, but it's definitely rare. Exosomes, you may have heard that term before. So exosomes are kind of like the new trend in regenerative medicine. It's kind of a step up from stem cells. So exosomes are tiny little bubbles that every cell puts out, not just stem cells, but every cell in our body puts off exosomes, and they're basically messengers that travel to other cells and communicate. And that communication is what carries the proteins and genetic information between the cells, along with a detailed message telling that next cell down the line what to do, kind of like delivering mail to a neighbor, right? And so exosomes can be utilized in terms of joints when we take those exosomes from stem cells. So they're basically stem cells that are further processed down to take just the exosomes that the stem cells put off. So when we inject exosomes, it's more of a direct way to talk to your body's own cells. The stem cells that we put in, we're putting in the donor cells and telling those donor cells to replicate. The exosomes are going in with a different messenger and reprogramming your body's own cells, if you will, just like a computer. And once that code is changed in your body's own cells, we know then that we reverse the age of that cell. So we, instead of having a stem cell in our knee that is naturally there since we were born, that's 50 years old, we give it a message from an infant age exosome, and it reprograms it and says, okay, I'm young again, and it restarts that healing process. And that healing process is what's able to repair the tendon, grow new muscle, grow new cartilage and bone. The exosomes do work a little more quickly, usually results before that 3-month mark, but just like stem cells or any other treatment that we're doing, it can take up to a year to get the full results for your body to go through that healing process. We can't ever guarantee results with treatments, but about 90% effectiveness in terms of these stem cells and exosomes. A lot of times when we do see where things didn't take as well, it's maybe if there were instructions after the injection that weren't followed, and we went and we did a lot of exercise, or we'll tell you not to take an anti-inflammatory for about 30 days, which can be hard for a lot of people because we've been taking these for long periods of time. So to say like, okay, you can't take your Advil or your Motrin, you can take Tylenol, and you're like, oh, but Tylenol, it doesn't work. Well, that's why we use that pinacetam polysulfate, right? Because it is a potent anti-inflammatory that we can use safely with these. So we know the benefits from that pinacetam polysulfate carry over, and so that's why that's part of that prep.
But you can't take Tylenol because it's not NSAID.
Yes, you can take Tylenol or acetaminophen. Yep, exactly. So that's the case whether we're doing a PRP injection or stem cell or exosome. We don't do an anti-inflammatory at least 7 days before, optimally 30 days before, and 30 days after. During that post-injection time period, we try to avoid nicotine if we can, try to avoid alcohol if we can, just trying to avoid any sort of external factor that could inhibit that healing cascade. We already talked about this, that it's rolling back the clock on your own cells. The steroid injections, a lot of people will get one injection, and then they'll go back a few months later and they'll say, okay, it's been long enough, you can have another injection. Okay, it's been long enough, you can have a third injection. I've had people who have had a dozen injections before, and what we know is that even after the first steroid injection into a joint, it will calm down the inflammation, but it causes damage. And that first injection might not cause a lot of damage, but it does cause some. By the time we get to the second steroid injection, we're kind of setting your joint up to fail, because we're taking away all of the cells that are trying to heal, and we're taking them away during that acute time period that we need them to be healing. So if anyone is getting steroid injections, I would recommend make an appointment, talk with us. We'll talk about alternatives, not even in injection form if you don't want to do a joint injection, but we can talk about alternatives like the penisan or things like that that can help to avoid that steroid going right into the joint. You know, the therapies we're talking about, they're not FDA approved. There's a lot of evidence that shows their benefit, but they're not FDA approved. PRP is FDA approved for use in the operating room, but that's it. The stem cells, the exosomes, PRP in an outpatient setting, the peptides, none of it's FDA approved. And so because of that, insurance doesn't cover it, right? And they are costly treatments in terms of the overall cost. However, to put it in perspective, you know, this is the data from 2022 on the average cost of a knee replacement, $45,000, hip replacement, $55,000, an arthroplasty, $50,000, shoulder, $55,000. And so in terms of avoiding surgery in the long run, they really are fairly affordable.
Insurance covers it in most cases.
To some point, yeah.
Until you pay your $8,000 deductible.
Right.
Yeah, yeah.
You have to pay your 20% of your maximum out of pocket.
That's your HSA max out.
Yeah, yeah. And then, you know, we have the effectiveness, right? So we see 90% improvement in terms of joint improvement with these regenerative therapies versus, you know, a knee is about 70%, a shoulder is about 45 to 50% was the last statistic. And so we have to think about not only the overall cost, but the success rate and the risks. So once you go through that surgery, you know, you are opening yourself up to risk as far as any damage that could be done to the nerves during the process, any damage that can be done to the blood flow during that process, as well as potential for infection. And unfortunately, you know, I'm a little biased to that, I suppose, because I've worked in the wound care world and seen so many failed joints. And I thought, oh, that never happens, right? But it happens a lot, where it doesn't take much. And it's not something done wrong during the surgery or something done wrong after, but we all have bacteria on our skin. And when we have an open incision like that, all it takes is a little bit of bacteria to move the wrong way and get in there, and it causes a lot of trouble. And so, you know, we're trying to provide some alternatives to that. The Elite Joint Program is something that Dr. Endel and I have been combining with his therapies that he referenced earlier. And so that combines that three-step approach of decreasing the inflammation with the peptides, the regenerative phase with those peptides, and then either a mesenchymal stem cell injection or exosome injection once all of those other factors are taken care of. So, and the A2M injection. So, you know, this isn't a cookie cutter type of plan. You may or may not need all of these type of treatments for it to be most successful. Some folks opt to just do a PRP injection, or just an A2M injection, or just a stem cell injection. But what we're trying to explain is how we can prime your body to best get the results from that, rather than spending a couple $1,000s to put a shot into your joint without changing the oil first, right, and getting that ready. So the protocol we use is doing the penisan polysulfate injections twice a week for 14 weeks, and then once a week for 8 weeks. And I do have some clients that continue that long term if they have a lot of joint issues. But the data from penisan itself shows that once we get to the 8-week mark, we have pretty significant improvement. But the 3-month mark, about 80% of people report significant joint pain improvement. Not just in the one joint that we're trying to deal with, but it's systemically absorbed, right? So we start that along with the BPC 157 and the thymosin beta 500 at the same time. and we also schedule you for the A2M injection. So with that, we're taking care of the inflammation, we're clearing out old cells, and then after we've gotten through those 8 weeks of the BPC 157 and the thymosin beta 500, then we move into that regenerative type of injection with the stem cells or the exosomes. We kind of already talked about this, the fact that they're not covered by insurance. I think they will be someday, but they aren't yet. And peptides in general, well, they are regulated to some extent, and there's been some changes. The FDA puts out a safety list every year, and if you've researched peptides, you probably are familiar with that, right? And so this year recently they added some common peptides that we use a lot in functional medicine and wellness practices to that safety list. And the purpose isn't because they're unsafe, but because a lot of people prescribe them that maybe don't know, right? It's kind of like someone prescribing chemotherapy if they don't know anything about chemotherapy, but there's no one to say stop with peptides. So that's what they're trying to implement with that, is that you have to have gone through a certification in peptides to be able to submit a prescription to the pharmacy to get it. And fortunately for you, I have. So there won't be an issue getting your peptides, but that it does affect a lot of clinicians that aren't trained.
I thought the other issue was that, for instance, BPC 157 is actually a synthetic version of that enzyme in your gut.
Mm-hmm.
So being a quote natural product, it also doesn't fall under regulation.
Well, the BPC 157, peptides are about as natural as you can get, but you're right, it is a synthetic, an analog to that. Mm-hmm.
Like a GLP-1 or any of those
Mm-hmm.
synthetic analogs.
Yep, exactly. I'm sure Dr. Indle is happy to talk to you about